Good evening, everyone. Welcome to the Prostate Forum of Orange County presentation for November 17, 2022. We are excited and honored to welcome Professor Leonard Marks, MD, of the UCLA Urology Department at the Ronald Reagan UCLA Medical Center. Dr. Marks received his MD and Master's of Arts in Physiology from the University of Texas and completed urology residency at UCLA. After a lengthy career in private practice, he returned full-time to UCLA in 2009. He is inaugural holder of the DeKernan Chair in Urology. Dr. Marks is principal investigator of 3 R01 grants from the National Institute of Health. He leads a multidisciplinary research collaborative involving urology, radiology, pathology, and bioengineering. He is known for his prostate cancer research and active surveillance, targeted biopsies, and focal therapy. And now, without further ado, I will mute myself and present Dr. Leonard Marks.
Brian, thank you very much. It was a beautiful introduction. I'm delighted to be here. I appreciate the invitation, Brian, Chuck, Neil, Arakagan, people I've known for some time, and I'm delighted to be here. The theme of tonight's talk, and permit me to indulge myself a little bit of the history buff that I have. We're going to talk about the evolution of prostate cancer management to where it is today. It is one of the most dramatic transformations in all of medicine. We came from a very primitive, in my opinion, a very primitive backdrop about a generation or two ago, but this disease has now been transformed. I labored with the title of this talk. Disease Transformed really gets it right, but I like this even better. It's not your father's prostate cancer. And I don't mean to denigrate anybody's father or their healthcare, but this is such a different disease. And I will show you why I've adopted this slogan in just 1 minute. The subtitle of this is how MRI-guided biopsy has changed everything for prostate cancer management. And if the only lesson you take away tonight, it's that the biopsy of prostate cancer, the biopsy of a man suspected of having prostate cancer, should in this time be guided by a preliminary MRI. After all, the biopsy is where a prostate cancer journey begins. And if you get the biopsy wrong, the whole journey will be badly affected. It's not your father's prostate cancer is not original with me. The paradigm has changed. The notion to use this as a kickoff for this talk came from some time ago. This is Mr. Ransom E. Olds, who is a gent working in his father's machine shop at the beginning of the 20th century. And he got tired of that and decided to start building cars. There were 200 companies making cars in the year 1900. His was one of them. His happened to become very successful. It became the Oldsmobile. And this became one of the best-selling cars in history. The brand is now gone. But in the 1980s, the Oldsmobile was very sluggish because it had only appealed to an older generation of men who were buying this car. And so to stimulate sales, the Oldsmobile company got together some Madison Avenue types and came up with this slogan: "This is not your father's Oldsmobile." They introduced Cutlass Supreme, which really reinvigorated sales. And the analogy here to prostate cancer is very appropriate because this is a lot new in something very old. So we have a completely transformed disease, and that's what I want to get across to you tonight. So it's not your father's prostate cancer. The whole paradigm of approach to this disease has changed. Previously, prostate cancer went like this. If you had a nodule or an elevated PSA, you got an ultrasound-guided biopsy, and these came out in the 1980s, the ultrasound-guided biopsy. Tom Staby at Stanford taught me how to do this. And we did ultrasound guided biopsies from the 1980s for the next 30 years uninterrupted. We thought it was terrific. The problem was you couldn't see prostate cancer with ultrasound. So we would take 12 or so many biopsies, hoping that if that elevated PSA was caused by prostate cancer, that one of those blind biopsies would show it. If any cancer was found on the biopsy, then the patient had prostatectomy or radiation therapy if he was lucky enough to be diagnosed early. And that's the way it was over the past two generations, from about the 1980s up until fairly recently. Now, prostate cancer is approached a different way. We still have to start with our nodule or
Join the meeting.
We still start with a nodule or an elevated PSA. But the biopsy now should be guided by a preliminary MRI, and I'll show you why that is. Now, if any cancer is found, there's no knee-jerk reaction. We have to categorize what we have found into low-risk prostate cancer, which is preferentially managed with active surveillance, severe prostate cancer, aggressive prostate cancers, which are preferentially managed with prostatectomy or radiation therapy, as in previous years, and a large growing group of men with intermediate risk prostate cancer for whom focal therapy is an increasingly attractive option. Just a word, and I know you're familiar with this, but just to impress upon you how seriously we take this problem. 270,000 new cases diagnosed every year in the United States, 35,000 deaths, second only to lung cancer as a cause of death in men. You have a 1 in 8 lifetime chance of getting it, even higher if you're an African-American man. It's a disease of middle and older years. And because it frequently has a long life natural history, over 3 million men are currently alive in the United States with prostate cancer. So this is what we are trying to prevent. This image shows a man with widespread metastatic disease occupying much of his bony skeleton. What we want to do is get to these cancers when they are small baby cancers living within the prostate, no metastases, to diagnose them early and characterize them accurately as to their severity and treat them appropriately, with increasing emphasis on treatments that do not disrupt quality of life. So MRI-guided biopsy is relatively new. The first ever publication of an MRI in the medical literature was only in 1983. This is a very basic preliminary look at the prostate, a T1 image. About all you can see in this is the Foley catheter in the man's bladder. The next landmark that happened was that an MRI-guided biopsy was performed. This was done by Tony D'Amico in Boston. Again, a fairly primitive approach to this problem, but that's when it started. The MRIs have become quite sophisticated over the years, and the MRI we'd like to see now is a prostate-focused, dedicated, multi-parametric MRI. Those three parameters, multi-parameters, being the T2 weighted image, which shows the lesion spatially quite well, diffusion weighted imaging, which measures how water molecules move around inside the tissue. It's sort of a density measurement, confirming the T2 weighted image here. Dynamic contrast enhancement, showing how blood flow goes in and out of the prostate. A contrast agent is used for this. And these correspond very nicely in this ideal situation to a cancer localized when it's removed to that part of the prostate. But what has propelled us more than anything is the ability to bring MRI to the patient's bedside using a device called an image fusion device. This is the one we use. It's called the Artemis, the same as the rocket that just went up yesterday into space. I always think NASA stole the name from us. Actually, Artemis was the name of the Greek goddess of the hunt. And I think that's a very appropriate name for this device because it allows us to accurately find prostate cancer. So these are some of the developments that led to where we are today. But what really got my attention, and this goes back to the 2008 AUA meeting, when I was sitting in the lecture hall during the Whitmore lecture, and Dr. Pat Walsh, who incidentally trained at UCLA, I've known him for a long time, a little older than me, but he was the man who taught the world how to take out prostates. And when he made this statement, it really got my attention. And when he said to the young people here, if you want to make a contribution to medicine for this decade and maybe for the century, address yourself to the problem of imaging cancer within the prostate gland. So here was a man who spent his whole life taking out prostates, and now he's telling us, wait a minute, let's see what we can see with imaging prostate cancer within the prostate. So the way these fusion biopsies are performed is that the MRI is performed in advance of the biopsy. The lesion is delineated by the radiologist. A line is drawn around it. It is contoured and furnished to the urologist that way. And then when the fusion is performed within the device, we can then see the region of interest from the MRI superimposed on the ultrasound image. So we've brought this sophisticated tool called the MRI to the patient's bedside and employed the very fine accuracy of the MRI with the simplicity and convenience of the ultrasound. Here it is, that here's how we target it. And the process involves a 3D reconstructed model of the prostate shown here with the biopsy sites recorded. So we know which ones hit the target, which ones are systematically placed throughout the prostate. And so the accuracy of MRI guidance is brought right to the patient's bedside. MR ultrasound fusion for targeted prostate biopsy. In the clinic, this is the setup. It's very similar to conventional ultrasound. This is a conventional ultrasound unit. This is our image fusion device. It can be done transrectally or transperineally. We'll talk about the differences in just one second. We were among the first in the United States to have image fusion prostate biopsy at our place. The Artemis device, which is made by a little company in Northern California, was the first one FDA approved, and we got it shortly after it was approved. The people at the NCI received approval from a different device made by the Philips Electronics company called the UroNav. And there's a few others as well. These two institutions have set the pace and made the largest collection of MR-guided biopsies in the United States. This is what our record looks like of an MR-guided biopsy, fusion biopsy. You can see the brown blob here is the prostate. These spots here, these green spots, are part of a template where we take systematic biopsies throughout the prostate. And this spot right here was the MR visible lesion, which has now been part of the ultrasound, allowing us to do targeted biopsies of this area. And the yield from targeted biopsies is a multiple of the yield from conventional ultrasound-guided blind biopsies. So the most important thing about using MR guidance and the way it helps us the most is called the PIRADS score, Prostate Imaging Reporting and Data System. This is an internationally accepted scoring system for the severity of prostate images. So this is a PIRADS grade 3. These are graded 3 through 5. When we see a PIRADS grade 3 lesion, as shown here, there's about a 24% chance that's going to harbor a clinically significant prostate cancer. When we see a PIRADS grade 4 lesion, shown here larger and darker than the 3, there's about a 37% chance of that finding a clinically significant cancer. And when we see a PIRADS 5 lesion, then about 80% of these will harbor clinically significant prostate cancer. The assignment of the PIRADS score is something that very few radiologists can do. So another message tonight is you should, if you're going to have an MRI-guided biopsy, it all starts with the MRI, and you have to be sure that the man reading these studies and the machinery being used to obtain these studies is state of the art, and you're going to somebody who has experience and knows what they're doing. When we started this, nobody else was doing MRs of the prostate. So if a patient came into me with an MRI that showed his prostate, almost always we had to repeat it. That's happening less and less frequently nowadays, as various radiologists are getting trained. One shame of the radiology societies that there's no credentialing, no certifying mechanism to declare a radiologist an expert in MRI interpretation. So we have to be careful that we're dealing with people who know what they're doing. We've done a lot of these, and I have great confidence in my radiologists. So what have we learned from the first decade of MRI-guided biopsy? Well, we learned that targeted biopsy is safe and efficient. It takes a few minutes longer than a conventional biopsy, but it's so much more valuable. High quality MRI is the key. The PIRADS grading system is the most important predictor of what we're going to find. If someone has a negative MRI, do we do a biopsy? If their MRI doesn't show a lesion? And the answer to that is it depends, because many prostate cancers, not many, but maybe 20% are MRI invisible. And so we have to take into account not only what the MRI shows, but other bits of information. I'll show you the next step beyond MRI guidance in just a minute. PIRADS, the most important predictor. Targeted and templated biopsies are both important for knowing where the cancer is and where it is not. And we've also learned that what's seen on the MRI does not exactly correlate with what's in the patient. This becomes very important when considering it for focal therapy. The margins that surround the area of interest become very, very critical in determining how to treat the patient. So let me show you one very rewarding area that has happened with our program here. Google has a function, whereas if you put in a list of street addresses, it'll spit out a map with a dot where each street address was located. So here's our Google map, first 2 years of our program. And you can see most of the dots are down here in California, especially Southern California. There was a few elsewhere, but most from our local people. Over the next 5 years, those dots began to spread out. And now they are going across the United States, the Hawaiian Islands. There's some occasional from Alaska and South America. And by this year, earlier this year, we just redid the map. Some 3,300 unique patients coming from 41 states in the Union, 15 foreign countries, 6 continents. And we created here a big business for UCLA Medical Center, because when these people come for the biopsy and they've been disappointed with what they've had locally, they typically stay for the treatment. So this is my way of giving back to UCLA, which has been a very excellent place where this is all sprung from. Been very supportive. A lot of transformative innovation has come out of the prostate sector at UCLA. We've learned how to do targeted and systematic biopsies using MRI guidance. And what I'm most interested in now is investigating how these biopsies can lead to reduction in morbidity of treatment by following a pattern that been established years ago by the breast cancer doctors. Previously, mastectomy was the only reasonable treatment for a woman with breast cancer, but a major trial was performed showing that lumpectomy, in many cases, gave equal results with much less deformity and much less morbidity of the treatment. So this is where we are right now, looking at the concept of focal therapy. The advantages of focal therapy: it offers the potential for cure with few side effects. It can be done as an outpatient procedure. It can be repeated if necessary, and it doesn't burn any bridges behind. It leaves the possibility of, if it fails, of later surgery or radiation therapy if necessary. Focal therapy evolved in an interesting way using the breast cancer model. This is somebody that you should be aware of. His name was Dr. Bernard Fisher. During the 1970s, when radical mastectomy was a knee-jerk reaction to breast cancer, he devised a clinical trial, which a few years ago culminated with many years of follow-up in women with breast cancer who had been treated with lumpectomy instead of mastectomy. His colleagues at that time did not exactly greet this idea warmly. Lumpectomy is murder, some of them said. This is equal to malpractice, some of them said. But over the years, things changed. And I couldn't help but clip this from Time magazine some years ago. In 1999, a New York fashion model lost her breast and became deformed and lost her occupation from breast cancer. She then sued the surgeon on the basis of there was no discussion of any other treatment, and the jury gave her $2.25 million in 1999. So what an evolution in the breast cancer world, from when lumpectomy is murder to you better talk about it or you can get sued. So this is an interesting little vignette that gives me confidence in what we're doing. There are currently 3 widely accepted methods of focal therapy in the United States. Cryotherapy is the oldest. It's done by placing hollow needles into the prostate around the region of interest and creating an ice ball. Temperature comes down to 40 below zero using argon gas, which circulates through the prostate region of interest and produces a freeze, which destroys tissue. It can be localized, and the prostate can be treated focally in this way. Another way that was approved by the FDA in 2015, more recently, is the use of HIFU, high intensity focused ultrasound, which is only a beam that goes transrectally into the prostate, and where the ultrasound beam comes to a point, heat is generated, boiling heat, and you can go speck by speck through the prostate, ablating cancers in a very precise manner. We are doing both of these on a regular basis. On the horizon is focal laser ablation. We are involved in clinical trials. I said my disclosure on the title slide that I'm a co-founder of a startup company that's interested in trying to commercialize focal laser ablation, which will have the advantage of being able to do this in a clinic outpatient instead of an operating room. But this is for the future. This is not quite here yet now, but these other 2 methods are here now and being utilized at our place on a regular basis in selected patients who sign a consent acknowledging they're in a clinical trial. There's no placebo group. This is an open label, prospective, observational clinical trial, and the data are carefully collected. The rules are established in advance. This is up on clinicaltrials.gov. So we're very formal in our methods of focal therapy. We still regard this as investigational, but it is moving rapidly into the mainstream. 5 compelling reasons why focal therapy makes great sense, beginning with our ability to localize cancer in the prostate with the MRI. It works very well in other cancers. Breast, I've mentioned, but colon cancer, if a man has colon cancer, they don't take out the whole colon, they take out the affected part. The same with thyroid, the same with kidney, and these are models that lead us to believe that this may work very well for prostate as well. The efficacy of whole gland therapy has been called into question by a number of large international prospective randomized trials of radical prostatectomy versus observation alone. The PIVOT trial you may have heard of. Our gold standard is not quite as golden as we thought it would be. It's still appropriate, I might say, for serious prostate cancer, and that's always my first choice. But for intermediate risk prostate cancer, maybe not so much. The fourth reason that focal therapy makes good sense is because of the monoclonal index origin of prostate cancer, a concept that says that although it may be multifocal, one of those foci in the prostate is the mother, and that will determine the metastatic potential of prostate cancer. And if you can wipe out the mother, you've done the patient a lot of good. And those other little cancers, which typically are small Gleason 6 cancers, have no effect on metastatic potential. And the main reason that this is moving forward very rapidly.
Something around there to start video. Where left, bottom left. Okay.
That speaks to groups like yours, is the
Still crossed out.
the desire of patients to have the least morbid treatment that will get the job done. When we poll our patients after focal therapy, their decisional regret remains very, very low. If you poll the patients the same way after radical prostatectomy, not so much. So we are very enthusiastic about the potential for focal therapy. We have done more cryoablations than anything else, partly because cryoablation is well covered by insurance and Medicare. It's the oldest form of energy used. It goes back a few decades. We have studied in these trials over 200 men during the past 5 years, and we judge success by follow-up biopsy. And at 6 months, about 75% of these men have no cancer. When we go back to the treated area, we can't find anything. At 18 months, this drops off a little bit. But about 2/3 of men, even at that intermediate range, 18 months out, we can't detect any cancer. Frequently, their PSA comes back. Frequently, the MRI reverts to normal. But we always rely on follow-up biopsy to prove that what we tried to do was in fact successful. Great thing about this, there's not been any incontinence that has resulted from this cryoablation. Erectile dysfunction is a plus-minus situation. We're talking about men in their 60s and 70s. Sometimes they'll even a little older. Father time is working against us. But whatever erectile dysfunction does happen, it's a fraction of what would happen after surgery or radiation therapy. So the takeaway message is that we advocate, and I think the American Urological Association, the European people would basically agree with this. Right now, focal therapy is for men with localized Gleason 7 intermediate prostate cancers, both 3+4 and 4+3. We're doing both. And prostates that are small enough to get our arms around these for good treatment, usually less than 50 cc's. With cryotherapy, we can go up a little bit larger. They have to be followed like they're in active surveillance programs. So it's not one and done. If somebody is not reliable, if they're not committed to follow-up, especially with that follow-up biopsy to confirm the results, then I'm not so interested in pursuing that option with them. So we follow them indefinitely, just like they're in active surveillance. We are still learning about the long-term efficacy of focal therapy. Up to 40% of newly diagnosed prostate cancer cases, let's get rid of that. Up to 40% of newly diagnosed prostate cancer cases may be focal therapy candidates. So this is something that we have to discuss with our patients. And we want this to be done.
Request for remote control.
Beg pardon? We want these to be done
I
in.
just had somebody unmuting themselves after I muted them, so they had some background noise. Yeah, I just muted them again.
Yes, it's awful complicated, Caroline Lennox.
We want these to be done in research protocols and not willy-nilly without good control and with data collection and reporting. So let's see here. So the way things have gone, and I'm very proud of this. We started with biopsies done over here at UCLA in 2009. We have followed that by interest in focal therapy and are researching this. And the latest horizon, which I know you've heard about because I believe one of my colleagues has spoken to you about this amazing new.
Oh, she's doing this, but I don't have any audio. See this audio up here? Charles Metzger's audio. Brian Social doesn't have any audio either.
Hi, could you please mute yourself, please? We're hearing you on the video here. Please mute yourself.
So PSMA scan, this stands for prostate-specific membrane
The
and
top left, that little red light over there on the top left.
I'll record, but this is kind of a yellow thing that says something's wrong here.
here's the hotspot, the PSMA uptake in a prostate, indicating a very likelihood showing cancer there. This became FDA approved.
Encrypted one exception.
Does somebody else want to give this talk?
I'm trying to get this person muted here.
This is the kind of scan I had, PSMA. But
Is this the iPhone person?
Cliff. Okay, it was Cliff, and I think we lost him. Okay, go ahead,
Okay.
doctor. I'm sorry.
Okay, so this scan combines PET imaging, which determines where the radioisotope is taken up, and CAT scan imaging together for anatomic localization. Let me show you some examples. This is a patient with a metastatic lesion from prostate cancer. Here is his ischium right here, and it looks normal on CAT scan, but when he undergoes the PET CT, you can see this hotspot within the ischium, which is a cancer. Prostate cancer metastasis not seen on CAT scan alone. Here's an example of someone with a lymph node from prostate cancer in the pelvis. You can see this right here. Under CAT scan alone, you can't see it. So we have not ordered, for staging purposes, CAT scans or bone scans for a long time. We ordered the PSMA scan, which offers the best opportunity, the most sensitivity for determining where and if there are any prostate cancer metastases. It's FDA approved. Now, it started out being only available at UCLA, where the clinical trial was done, and UCSF, the sister institution. But now a commercial enterprise has become involved and has produced an excellent PSMA scan, which is available now in virtually every metropolitan area in the United States, called the PYLARIFY scan. It's widely available, and it's an excellent scan. Now, it turns out not all prostate cancers is seen on MRI. As I said, maybe 20% are MRI invisible. Let me show you a very interesting case report. We reported this a few years ago, but very interesting. 71-year-old man with a PSA rising step by step up to a 49. You all know that's a very high number. He had 3 separate MRI studies over those years. All 3 of the studies, and one done at UCLA, showed no lesions. 6 sets of biopsies totaling 74 different cores of prostate tissue taken by different operators, all negative. So he came to UCLA during the period before PSMA was available, widely available. It was still in clinical trials. And sure enough, this PSMA scan showed a hot spot in the prostate. We were able to do a MRI, a PET CT fusion with ultrasound, and in our clinic, performed these targeted biopsies. And sure enough, this man had a cancer. He's now 5 years post radical prostate.
Why?
We reported this, the first ever report of this kind in the medical literature a few years ago, and are now involved in a clinical trial to take this to a higher level. It may be that PSMA targeting is more valuable even than MRI targeting has been so far. So just to tell you a little bit about what our organization has done over the past few years, I'm very happy to have been involved. We would be the 2009, when I first started working on this, we got a pathologist, we got a radiologist, we got a biomedical engineer, research coordinator, and a urologist, and we began doing our procedures. This group stayed together a number of years. All of these people have moved on to better jobs now, except me. But I've got a good job already, and we're gonna keep at it. We've now done probably more targeted biopsies than any other institution in America. Over 5,000 of these, involving more than 3,000 separate patients. We're using this in our active surveillance program as well. We've had 132 national presentations, over 100 peer-reviewed publications in the medical literature, some $6 million in NIH funding. A startup company has been launched. I disclosed this at the beginning to try to commercialize focal laser ablation using an in-clinic approach. But most importantly, countless lives have been affected, including maybe some of your own members. It's a common occurrence to have someone who comes in with a conventional biopsy that didn't show anything, but his PSA level continued to go up, or maybe there was a nodule palpable in the prostate. He came, he had the biopsy, it showed where his cancer was, and he got appropriate treatment. And these are very grateful patients. They've helped us. We've helped them, and frequently they've helped us philanthropically as well. So this has been just a wonderful adventure over the past dozen years. That small research team you saw originally has grown into this. And if you look at what these people do, you'll see there's essentially one of everything in here, so that our multidisciplinary approach has grown and prospered. And if you come, you'll see these people. To close this program, I want to reinforce to you the analogy of something new and reinvigorating in something old. So it's not your father's Oldsmobile, and I wonder if any of you remember this. Well, oops. Thank you for having me tonight. We're very proud to be at UCLA and do this work with our people, #1 public university in America. And if I can answer questions, I'll be happy to do so.
Well, we happen to have some questions for you. Let's go way up on top here. By the way, I put in the chat the doctor's website, and you'll be able to save the chat yourself once this presentation is over. Let's take a look at Francisco Garcia, who wants to know, do you think HIFU a recommended solution for advanced cancer 70% plus Gleason 7 and 8?
Gleason 8 scares me. Gleason 8 is a more aggressive cancer than Gleason 7. We reluctantly treat a few patients with Gleason 8 who have said they'd rather die than have surgery or radiation therapy, provided that tumor is not extensive within the prostate, that is fairly well localized, and the prostate is small enough to deal with. So we don't normally include them. Our clinical trial inclusion and exclusion criteria do not include Gleason 8 specifically. The European data is interesting in this regard, and the British, who use this more often in advanced prostate cancers, and in the half a dozen, 6 or 10 that we've done, the results are about the same as in the ones with intermediate risk cancer. But I'm not enthusiastic about it, and I kind of do it under protest.
Okay, and Frank has a question. Focal therapy, can it be done with an intermediate to high-risk Gleason 4+3. So now we're getting back into that 7 range again.
We do 4+3s. 4+3s have a slightly more aggressive tendency than 3+4s. So again, it would depend upon the lesion. It would, if it's a very high volume 4+3 and it's a young man, I would be cautious about this. But low volume 4+3, well localized, I have no problem with that. We are treating those patients and they're doing as well also. The 18-month data shows they fail a little bit more often, but it's not terrible, and we can still do something else like surgery or radiation if they do fail. You've got to remember every treatment has a failure rate. So I'm not embarrassed that focal therapy has a certain failure rate. We recognize it. We recognize it early in time to change course or to repeat the treatment if necessary.
Okay, Howard wants to know, under focal treatment, mentioned ablations, not radiation beam. How come? We've been talking a lot about focal radiation in our group.
Yeah, this is, well, I'm not a radiation therapist, so I'm not the right one to ask that question to. But radiation therapy has a number of complications that you should be well aware of. In fact, at 5 years out after surgery, radiation therapy or surgery have about the same incidence of erectile dysfunction and incontinence, with the added problem of rectal toxicity. So I think it's commendable that the radiation therapists want to localize their treatment more. I think this is something that has not been studied very much, and I look forward to seeing more information on it. I think the radiation therapists do have the tools that allow them to focus this a little bit better, specifically with using brachytherapy or interstitial radiation therapy, where they can actually put those wires directly in access to the prostate and don't have to treat the whole prostate. But I don't think there's much published on this, so I look forward to seeing it.
Okay. I'm going to call on George, who has a question for you. George, if you'd unmute yourself, and please ask your question.
Yeah, unmuted, and I don't want to take everyone's time because it doesn't seem like the presentation is focused on the level of advanced cancer that I have. But I was just wondering if you could make a couple of comments on what's the cutting edge for the people that are stage 4, you know, and trying to live.
Well, this is the province of an oncologist. As I showed in one of the early slides, our mission is to get to this before it gets to be an advanced metastatic situation. But I can tell you, lives are being extended every day. I share my office one day a week with an excellent oncologist, and I know that there are a whole variety of treatments. Abiraterone, Zytiga, was a huge advance. There are many others as well, and I don't think it's necessarily game over, but we sure do want to find this disease early, like any cancer. I wish you all the very best.
Neil?
Yes.
Yes, Dr. Marks, thank you very much. This is a John Wooden type lecture that we've been looking forward to for a long time. We appreciate your calm demeanor and the research and things you've done for our patients, but seems like an awful lot of our guys on the forum have been patients of yours. We just really appreciate this excellent lecture, and just well worth the feature lecture of 2022. So we thank you very much.
Thank you very much. Outstanding lecture.
Thank you. It's been a pleasure for me and fun to see Ira Caggett and others who I've known for a good while. Good luck with your mission. You have a wonderful mission.
Well, I promised Ira you would use extra KY the next time he came in. So
No, that's going to cost him extra.
okay, well, I'll leave that up to you.
Okay. Good night.